Good afternoon, everyone. So today we are all gathered here to over the topic dealing with depression in type 2 diabetes mellitus. Hello, my name is Dr. Akash Chaudhary. I'm a second year resident in Psychiatry Department, Subharti Medical College. So first we'll go through what depressive disorder is all about. Depressive disorder are characterized by sadness, severe enough or persistent enough to interfere with the function and often by decrease in stress or pleasurable activities. It comprises of symptoms like thoughts, like poor concentration, indecisiveness, sexual interest, lack of sexual interest, mood changes, there's lack of interest and feeling sad, bodily function, unexplained pain, sleep disturbances, and psychomotor functions, slow body movement or psychomotor retardation. Are depressed patients more likely to be medically ill? So basically this prevalence of comorbidity in depressed patients over a sample size of 1500 patients consisted of musculoskeletal pain, respiratory diseases, upper GI disturbances, neurological conditions, and endocrine conditions. Depression with chronic complications in patients. There is a high prevalence of both physical and anxiety-related psychiatric comorbidities among patients with depression. The chronic somatic problems associated with functional limitations, disability, or pain may lead to emergence of an emotional distress, irritating, and depressive episodes. Depression lowers the threshold for pain, activates stress hormone response, worsens cardiovascular parameters, including hypertension, and increases the risk of type 2 diabetes mellitus, which I further explained in the upcoming slides. So, depression in type 2 diabetes patients. Depression with diabetes epidemiology. Prevalence of depression in patients with diabetes as depicted in a systematic review. Both in type 1 and type 2 diabetes, both the prevalence increases of type 2 patients with depression is found. Prevalence of diabetes and cardiovascular diseases in depressed patients with anxiety disorders, which more comprises of hypertension as compared to other cardiovascular diseases, followed by diabetes. Depression and diabetes. So basically, when both of them get combined, there's poor glycemic control, increased functional disabilities, increased cost of care as there is poor adherence to the treatment given to the patient as he is suffering from both diabetes and depression, which both require a long-term treatment. This increased complication and 2.5 times likely to die in 8-year follow-up study. So basically, if somebody is just suffering from depression as compared to both depression and diabetes mellitus, the chances of dying increases 2.5 times. Etiological link between depression and type 1 diabetes. So the three parameters that we're going to discuss over here is increased cortisol, oxidative stress, and increased cytokines and increased catecholamines. First, there's hypo or hyperactivity of hypothalamic pituitary axis, which further increases cortisol levels, leading to beta cell destruction in pancreas and poor glycemic control. Leads to type 1 diabetes mellitus. Same goes with oxidative stress, such as smoking, or other medication which causes these oxidative stress leads to further deterioration of beta cell health, followed by this activation of sympathetic nervous system as compared with in hypertension leads to increased cytokine release and further depletion of beta cells in type 1 diabetes mellitus. Due to poor functioning like poor functioning, poor growth of the body, the patient gets more depressive symptoms comprising will he ever get well, has he or her had to take medication for the lifetime, which further leads to depression and the vicious cycle carries on. Etiological links between depression and type 2 diabetes mellitus. Again, the path is basically similar to type 1 diabetes mellitus. Hyperactivity of hypothalamic pituitary axis leads to increased cortisol, increased insulin resistance, which further leads to type 2 diabetes mellitus, followed by depression. It is not necessary, it's not a rule that everybody is suffering from type 2 diabetes will go through depression, but the likelihood increases significantly. Activation of sympathetic nervous system further leads to increased cytokine release and insulin resistance. There's family history, multiple stresses such as obesity, increasing age, smoking, lifestyle, lack of exercise, unhealthy diets, which further leads to depression and both diabetes mellitus. Relationship of major depression to diabetes symptoms. So basically here we're gonna see the overlapping symptoms that the patient presents to us in both OPDs of both medicine and psychiatry. There's increased daytime sleepiness, which is the most common overlapping symptom, followed by feeling faint, blurred vision, shakiness, abnormal thirst, excessive hunger, polyuria, cold hands and feet. So if somebody is going through daytime sleepiness or somnolence, always we should keep in mind as psychiatrists that the patient might also be suffering from poor glycemic control. A longitudinal association between depression and diabetes complication, a systematic review and meta-analysis. So according to this meta-analysis, there was increasing risk of developing diabetic complication in depressed patients. by 38 and 33% for both macrovascular and microvascular complication respectively, is higher than the increased risk of developing depression by 9 to 24%. So basically it's quite significant result. Both macrovascular and microvascular complication increase in patients suffering from both diabetes and depression, and the risk is quite significant. Depression decreases medication adherence in patients with diabetes. As the patient is not able to think clearly, he is not able to comply with medications. And it's a slow killer. As we all know, diabetes patient, there's poor adherence, which further leads to poor glycemic control in these patients. So both go hand in hand. As compared to depression and diabetes, both there has been found that patients who are depressed are more likely to be non-compliant to medication for both diabetes and depression. A brief graph of glycemic control in depressed and non-depressed patients. Non-depressed patient, as we can see, there's a more stable graph that has been achieved as compared to depressed patients, in which thus there is a skyrocketing of both glycemic control and poor adherence for the medications. Effects of depression on all causes mortality in diabetic patients. Diabetes depression is the leading cause of mortality as compared to other specific symptoms. If patient is just suffering from depression, then there's the mortality rate. If no diabetes, just depression, diabetes with no depression, and in the end, both diabetes and depression, which has led to significant increase in the chart due to high mortality if persons suffer from both comorbidities. So what treatment strategies can we further intake? Maintaining diabetes consists of these general goals: regulate blood glucose, blood pressure and lipid profile and their associated symptoms, identify and treat macrovascular and microvascular complications, effective cell management by the patients, improve or stabilize the general health status of the patient. One more point to keep in mind is that unless until patient is mentally fit to take care and understand about the effectiveness of the treatment that he has to adhere to, patient should be mentally fine and should be willing and motivated to take these medications regularly and has to be counseled forever. That's why it is important for the patient to increase the lifetime and their lifespan if they adhere to the treatment plan. Pharmacotherapy, selective serotonin reuptake inhibitors such as fluoxetine, paroxetine, citalopram and sertraline not only improve depression but also help in reduction in glucose levels. It helps improve the severity of depression and limits effects of reduction in HbA1c levels. Studies which has focused on behavioral modification or collaborative care in depressive diabetics had improved outcomes and adherence to these medications. Improved depression care in diabetes, more depression-free days over 2 years. So the more the patient was free from depression, there was significant impact in the adherence of the patient for both diabetes and depression. Many obstacles to treatment of depression and comorbidities with medication. So just adequate dosage and adequate duration are just the tip of the iceberg that we can offer the patient. But the main problem lies with the lack of efficacy, non-adherence to the treatment, comorbidities, safety issues, and poor tolerability. Classes of antidepressant that we can give to the patient comprises of different classes, consist of tricyclists, MAO inhibitors, SSRIs, SNRIs, and further classification of drugs. So sertraline, an ideal choice for depression with chronic comorbid illnesses. This is basically the kinds of action of sertraline. It binds to the transporters for serotonin and dopamine receptors, which due to their further inhibition leads to its effect. Sertraline has a higher in vitro potency for serotonin reuptake inhibition than the SSRIs fluoxetine and citalopram, and other tricyclic antidepressants clomipramine and amitriptyline. It's a potent inhibitor of serotonin reuptake compared to other SSRIs. Sertraline is also relatively potent in vitro inhibitor of dopamine reuptake, so it both increases serotonin and dopamine levels with further improvement in both low mood symptoms. Temporal sequence of effect due to dual reuptake inhibition. On phase 1, the anxiety cluster, phase 2, 17 to 21 days depression cluster, and 21 to 56 day hedonic cluster. It basically shows the cycle of how the drug acts and over period of time, how there's improvement in the patient. There's inner tension in phase 1, worry, irritability. In phase 2, there's alleviation of mood tone, alertness, and improved concentration. And further in hedonic cluster, there's renewal interest in sexual and pleasurable activities. So be patient and keep on educating the patient that how the drug will work and how the symptoms will resolve over the period of time. Indications and dosage. So basic different indication for sertraline comprises of major depressive disorder, obsessive compulsive disorder, panic disorder, post-traumatic stress disorder, premenstrual dysphoric disorder, and social anxiety disorder. The maximum dose comprises of 200 milligrams per day and should be started on 25 milligrams per day, except patients in MDD, OCD, and premenstrual dysphoric disorder. The recommended dosage comprises of 50 milligrams per day orally. Clinical evidences, effect of sertraline as an add-on therapy in type 2 diabetes patients with comorbid depression. An open label randomized control trial suggested that sertraline significantly improves depression and drug adherence in type 2 diabetes patients with depression. Another study of cognitive behavioral therapy versus sertraline in patients with depression and poorly controlled diabetes. The diabetes and depression study. Depression is a common and potentially life-threatening comorbidity in diabetes. Depression improved under CBT and sertraline in patients with diabetes, and depression with a significant advantage with sertraline. So both, if the patient is on cognitive behavioral therapy and on pharmacotherapy, the results are significantly way better as compared to if patient is not at all on any of the pharmacotherapy or psychological treatment. Impact of sertraline on weight to waist circumference and glycemic control. A prospective clinical trial on depressive diabetic type 2 patients. Sertraline improved anthropometric variables in depressed type 2 diabetic patients. At week 12, sertraline 50 mg produced 2.5% loss in body weight from baseline. Depressive patients under sertraline lost an average 7 continents in waist circumferences. Sertraline was effective and safe in depressive diabetic type 2 patients as well. So it works both in reduces waist circumference, patient starts feeling good about himself or herself, and increases the adherence towards the treatment, as they can see the significant improvement in both bodily image and glycemic control. Sertraline for prevention of depression recurrence in diabetes mellitus. In patients with diabetes, maintenance therapy with sertraline prolongs the depression-free interval following recovery from major depression. Depression recovery with sertraline as well as sustained remission with the without treatment are associated with improvement in HbA1c levels for at least 1 year. So in this graph, it is depicting that more the depression-free days when the patient is on sertraline, there's improvement in both the diabetes mellitus as there is good glycemic control. As more the patient is depression free, the more are the chances that he will be adhering to the treatment and will be more involved in both physical and activities to control the poor glycemic control for the patient. Sertraline hydrochloride treatment for patients with stable chronic obstructive pulmonary disease complicated with depression, a randomized control trial. Patients with sertraline hydrochloride group showed more changes in HAM-D score and CAT score. So CAT score is basically the score which measures the COPD symptomatology in COPD patients, and there was significant improvement when the patient was on sertraline as compared to standalone COPD treatment. Antidepressant treatment can improve the quality of life and exercise capacity of patients with depression, and it can also improve depression scores. Sertraline improves depression scores in the elderly in short term, regardless of medical comorbidity status. Sertraline was efficacious in reducing depressive symptomatology, regardless of presence of comorbid medical illnesses. Sertraline was safe and well tolerated by patients with or without medical illnesses in geriatric population. Prevalence of physical comorbidity and prescription patterns in elderly patients with depression, a multicentric study under the aegis of IAGMH. Sertraline was the most preferred antidepressant in elderly and depression, both among those with and without physical comorbidities. The presence of physical comorbidity associated with more frequent prescription of sertraline. So a brief summary, broad spectrum antidepressant offer most favorable balance between benefits and acceptability. Drug of choice for major depression in diabetes patients. Favorable action on cognitive function as compared to other antidepressants. Minimal drug to drug interactions. Safe in elderly patients. Must be taken on full stomach for better absorption. Thank you.